Extract 1. Questions 1 to 12. You hear a vet talking to a pet owner called Tony Davis. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Oh, she's fine overall. I just think it's time I did something about this.
What seems to be the problem?
Well, recently Bubbles has been acting a little bit strangely. When I take her to the park, for example, she'll pick fights with the other dogs just because they're, well, there. She barks so loudly, it's really embarrassing. Then, don't get me started about when she sees any males about. She acts really, well, randy. I've had Bubbles since she was a puppy, so I know when something's up.
Remind me how old she is now?
She's 2.
All right, and what are you suspecting?
I don't know. I was reading around on the internet about what happens to a dog when she's in heat, and she's displaying all the usual signs.
Is Bubbles your only pet?
She is. We were considering another, maybe a German Shepherd or a Dachshund, but I don't know if she'll be able to cope with that.
I understand your concerns.
Will she always be like this? Is there something we can do? It's getting to be a right pain. The neighbors have a pit bull, and the other day I caught him leering at her. He got pretty violent. We've got a huge hole in the fence that I'm pretty sure was down to him trying to bash his way through.
Have you ever considered spaying Bubbles?
What's that?
It's abdominal surgery to prevent her from becoming pregnant. The medical term for it is ovariohysterectomy, when both the ovaries and uterus are removed. She'll have a faint scar on her tummy, but other than that, you won't be able to see anything. She'll be much calmer afterwards, and you won't have to worry about annoying or messy heat cycles.
Oh, goodness, no, I wouldn't want to hurt her. Is there any other way?
Don't worry, it's a relatively painless procedure, and it's all done under anesthetic, and it's over within 2 hours. She'd come in, we'd give you the painkillers for her afterwards, too. Plus, an Elizabethan collar to stop her from interfering with the stitches. There are other health benefits, too.
Really? Like what?
Well, for one thing, it'll reduce her risk of contracting breast cancer or a womb infection, which is something that can be fatal. Plus, pregnancy in dogs can be quite a big risk that can produce medical complications. The list is endless, really. I can only imagine that she creates quite a bit of mess around the house when she's in heat.
You've got that right. All of those months we spent getting our house trained, and now this. Okay, I think it's something that I'd like to do. Like you say, there are lots of health benefits, and I'd like Bubbles to live a long time. Plus, I'm sure you've done this plenty of times before.
Oh, absolutely. It's a common procedure.
It sounds like there are a lot of positives, but what about the drawbacks? Will she change at all?
Her metabolism will likely slow down after she's spayed, so you'll need to feed her less and keep up or gradually increase her exercise routine.
Okay. If you think it would help. How soon could we have this done?
As soon as next week. I'll check to see if we have the space. Just make sure she hasn't had anything to eat beforehand. The food could react with the anesthesia and make her feel nauseous.
Okay. And you say it'll all be done within a couple of hours?
Yes.
What about after the procedure? My partner and the kids have got into a routine with Bubbles now. We each take turns to feed her and walk her. Can we just carry on with our normal routines?
Absolutely. The day after the surgery, she can eat normally. One thing I would say, though, you would need to limit her exercise for about a week after the surgery. I'd also keep her indoors for a little while.
Okay. So we just ease her back into the routine?
Right.
Okay. I'll discuss it with my partner, make sure he's okay with it, and then I can call to book in if that's okay.
That's absolutely fine. Take your time. It's a major decision.
Hello, I'm Julian, one of the nurse practitioners here. How can I help you?
Well, Julian, I've got some pain in my sort of the lower part of my tummy, actually.
Right. Okay. And have you noticed any other symptoms apart from that abdominal pain?
Well, the pain's there sort of on and off, but then when I have a wee or go to the loo, it really hurts.
Right. It hurts when you go to the toilet. Right.
Yeah.
Okay. And how long have you had that abdominal pain for?
I think it's been about a week, really.
Right.
Sort of on and off, not all the time.
For about a week. Okay. What about the pain when you pass urine? How long has that been for?
I suppose towards the end of the week, and then really over the last 3 days, that seems to have got worse.
Right.
And now it feels like if I, as soon as I need to go to the loo, I've got to go. I feel like a real urgency to go, and it seems like I'm going to the toilet more often.
Right, okay. So some pain passing you in the last few days, and then more recently had to go to the toilet more often,
Yeah.
and you feel like you've got to go all the time.
Yeah. And in the night I now have to wake up and go to the loo.
Right, you have to get up at night as well. Okay, all right. Have you had any problems like this before? Any this type of urinary problems?
I suppose I had something sort of similar, about 2 years ago actually.
Right.
And it sort of felt about the same.
Right, and can you remember what that problem was?
I think they said I had cystitis.
Right.
Yeah, cystitis, and I had to have just some antibiotics.
Oh, some antibiotics. Okay, and did it go away then?
Yep, it went away, and I don't think I've had anything since.
Right. Okay. Fine. Have you still got the abdominal pain at the moment?
Yes.
Okay.
Not too bad,
Not too bad.
but it's there. It's just sort of in the background.
Okay. Is it there all the time, or does it go up and down?
I think it goes up and down really, but worse perhaps when I'm having a wee.
Okay. On a scale of 1 to 10, with 10 being the worst, how would you rate the pain?
It's not that bad. I think it's probably about 4.
About 4.
3 or 4.
Okay, so not so bad. Okay. Have you taken any medicines at all for this problem?
Well, I did take a couple of paracetamol,
Okay.
and that seemed to help with the pain. Obviously, it doesn't stop me needing to go to the loo all the
Right.
time.
Would it help with the pain a bit? Okay. Good. All right. Now, I just wanted to ask about some other symptoms related to this. Have you had any fever at all, like feeling hot?
No.
No. Have you felt sick at all?
No.
Okay. Have you noticed any blood in the urine?
Oh, no.
No? Okay. That's
Should
good.
I?
Well, if you did, then we'd want to do something
Oh,
about
no.
it. If you haven't, that's fine. Okay. And have you noticed any unusual vaginal discharge at all?
No, just the same really.
Just the same, okay. And any unusual vaginal or vulval irritation or spots or sores since you've had this problem?
No, just the sort of pain that feels like it's inside when I'm having a wee, but I haven't noticed anything.
Okay, fine. Okay, and do you have a partner at the moment?
Yeah, I'm married. Been married 5 years nearly.
5 years, okay. Right. When did you last have a sexual health screen?
I think it was, when before we started going out with each other, so as we were going out, it's probably about 6, 7 years ago.
Right, okay. All right, fine. And I need to ask this question in relation to possibility of sexually transmitted infections, but have you had any other sexual contacts
No,
recently?
I haven't.
No. Okay.
Oh,
Well-
maybe my husband has.
Okay. Well, we're just checking to see if there's any risk for sexually
I don't
transmitted
think so.
infections. Okay, that's fine. And I just need to ask about your period as well. When was the first day of your last period?
What day is it today? About 2 weeks ago.
2 weeks ago. Okay, was that as normal, do you think?
Normal.
Okay. Do you
No
think there's
problem.
any risk of pregnancy?
No, because I have an implant.
Right, okay. Fine, okay. That's all right. Now, so how often would you say you're going to the toilet during the day?
Oh, it feels like I could go every 5 minutes,
Right,
really.
right.
I don't know.
Okay.
Quite more than I would normally go.
Right, okay. And have you been able to go to work, or you've had to take time off?
Well, since it's now feeling like I might wet myself if I don't get to the loo
Right.
quick enough, I've taken the last two days off.
Right.
just because I work in a really busy office and I can't bear the thought of that happening at work.
Okay, fine, all right. Okay, so you've mentioned that you've had cystitis before in the past and you had some antibiotics for that.
Yeah.
I just want to ask about some past medical history problems. Have you any other illnesses or operations in the past that I should know about?
No, nothing really. I've always been really healthy. I mean,
Okay.
I had this sort of cystitis thing 2 or 3 years ago. But
Okay.
other than that,
All right, fine. Okay, so I just wanted to ask about medicines as well. You mentioned that you're taking paracetamol
Yes.
for this problem and that got an implant as well. Do you take any other medicines?
no, I mean, sometimes I might take ibuprofen if I need to,
Right.
but nothing regularly.
Okay,
No.
fine. And are you allergic to any medicines
No.
you're aware of?
No,
No. Okay.
not that I found out.
Fine. And what sort of job is it you do?
Well, I work in an office, but I'm just a secretary.
Right, you're secretary in an office. Okay.
Mhm.
And you're married.
Yeah.
Have you got any children?
No.
No. Okay. All right. And just thinking about your weekly alcohol intake, how much do you think you would drink normally?
Not very much, really. Probably a couple of glasses a week.
Right.
So just depending on what's going on, but most weeks probably minimal.
Right. Okay. Okay. Good. And what about smoking?
Well, I've been really good. I
Yes.
used to smoke.
Oh, okay, yes.
I think 3 years ago now I stopped and I haven't smoked
Right.
since.
Okay. Oh, that's good. That's good. Well done. Okay. And what about exercise? You take any exercise?
On a Monday night after work I go swimming.
Yes.
And I do walk my dog
Right.
2 to 3 times.
Okay. Yes, that's good.
But nothing else.
All right. That sounds okay. All right. And have you had any travel anywhere recently, say outside of the
No.
UK?
We're going in a couple of months, but we did actually go. I think our last holiday we just went to Ibiza last
Right.
summer.
Okay. Fine. So nowhere exotic, really. Okay. And what were you thinking this problem might be? Did you have any
Well,
thoughts?
It seems very similar to what I had a couple of years ago, really. So I think maybe I've got cystitis or a urine infection.
Oh, right. Okay. Yes, it does sound a bit like that, doesn't it? Yes. Okay. And what were you thinking to do about the problem today?
Well, as it worked so well before when I had the antibiotics, I thought maybe I should have some antibiotics because it doesn't seem to be getting better.
Yes.
It's
Yes.
getting worse, really.
Okay. Fine. All right. Okay. Well, I think that's the end of my questions I want to ask you. So that was the end of my history taking station. So I'm just going to switch the video recorder off.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen.
Question 25. You hear a morning brief in a hospital ward. Now read the question.
So what do we intend to do with Miss Lannister today?
Oh, which one is Miss Lannister again?
Bed 4, subarachnoid hemorrhage.
Ah, right. According to the notes from the neurotelemetry unit, her condition is stable and has been for some time. I don't see a reason why she can't be discharged today, preferably to a rehabilitation centre in the community.
I'm really sorry, but I don't think that's a good idea. You see, the team thinks that there's a high likelihood that she might relapse soon, and I'd hate to let her go so soon. Perhaps if we could keep a close eye on her condition, if only for 2 to 3 days, and if all is well, then we proceed to discharge.
Okay, that sounds like a good way forward.
Question 26. You hear podiatrist talking to a patient about her swollen foot. Now read the question.
All right, let's take a look at you. Oh, okay, I see it here. Miss James, you've got some discoloration on your medial plantar region here, and a little here too. I can see from your notes that you're also concerned about the pain that you have right here. I think the problem is that you have multiple contusions in these areas here and here. The pain is therefore radiating through your foot. I'd like to see to it that you get stronger painkillers today for this, and perhaps a cane too. I'd like to have you back to a position where you've got a full range of motion, where you're fully ambulatory too. We're not going to get that with you ignoring this pain, okay?
Question 27. You hear a nurse talking to briefing her colleague about a patient. Now read the question.
Has the physio finished with Mrs. Bryant yet?
Yes, I think I just saw him leaving. He was with her a really long time after her fall this morning. Hey, let's flip a coin. Heads, you go and give her a debrief. Tails, I draw the short straw.
Oh, stop it. She's not that bad, and I'd be happy to go and talk to her. You know, Mrs. Bryant's really quite interesting once you get to know her.
I'm sure she is. Just make sure that you read her medication sheet carefully, and we don't give her one that she'll have a reaction to. Mrs. Bryant can be pretty sensitive.
Hey, it's not her fault. What's with you? You're not usually this, well, cold about patients. Did she do something to bother you?
I think the constant complaints from her have started to grate. But you're right. I'll get it under control.
Question 28. You hear a nurse asking her colleague for help with a patient. Now read the question.
Stephanie, do you have a moment? I've taken a look at the list today and noticed that Brienne Gargo is on it. I know that you treated her last, and I was hoping for some advice and or assistance. The receptionist managed to take a brief about the reason for the visit, and according to them, she booked an emergency consultation. As you know, these are usually reserved for patients who are in a lot of pain, and I fear that this is the case here. You see, I took a quick look at the x-ray you took last time, and from this, it would appear that Ms. Gorgo's condition is deteriorating rapidly, and I'm very worried about this particular operation. As a precaution, we need to make sure that we have enough painkillers on hand for today. Would you please see if you can free up some time later on and assist me? Thank you.
Question 29. You hear an optometrist talking to a patient who is trying contact lenses for the first time. Now read the question.
I think one of the reasons why clients prefer contacts to glasses is that element of choice. Sure, you can always change frames, but they won't alter your look as drastically as the contacts will. So make sure you make that choice wisely, okay?
Choice?
Absolutely. We can match your natural eye colour, or, if you would like, you can try on a different shade like hazel or blue.
I think I'll stick with my natural colour, if that's okay.
That's fine. Here you are. I'll give you a moment to put them on. How does that feel? Are they comfortable?
It feels fine. I guess the only thing is... should it be this fuzzy?
Not at all. And if that's happening, please take them out. We'll need to check the prescription again. Would you please give me a moment?
Question 30. You hear part of an antenatal consultation. Now read the question.
Steve mentioned that you had some questions for me about the information we went over this morning.
Yes, that's right. It's mostly to do with the plans for the next few months. This is my first, you see.
Right.
And I'd like to give her the best possible start. I've heard all sorts about the whole process, and it's tough to figure out what's reliable, you know? Like, apparently there's a high chance of developing depression after her birth, and there's lots of information out there, but nothing that tells you what causes it or how to prevent it.
I see.
And don't get me started about the best foods to eat. You know, I actually read an article the other day that said to avoid lemons if you're carrying a girl.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
The way that we teach clinical history taking at Warwick Medical School is to use the 4 frames. And the 4 frames are a logical way to take a comprehensive history and not miss anything out at all. So the first frame is the presenting complaint and the history of presenting complaint and the systems review and the red flags. So we encourage our students to ask an open question so they can start eliciting the symptoms from the patient. Then we would click into one system. What I mean by that is that if somebody has chest pain, for example, then you would clearly need to ask about all the cardiac symptoms once you've got a lot of detail about the patient's pain using a mnemonic such as SQUITAS, which is site, quality, intensity, timing, aggravating factors, relieving factors, and associated symptoms. I think then it's very important to ask about other systems. So we would do a systems review and then finish off by recapping the red flags. That is, for example, blood anywhere, lumps and bumps anywhere, weight loss, change in appetite, change in bowel habit. The next frame could be the past medical history. We'd ask about operations, any other significant serious conditions. They would ask about the drugs, because they would often be related to the past medical history. And they would ask about over-the-counter drugs as well, and also check on recreational drugs. We will then move on to check allergies and food intolerances. With respect to allergies, it's very important to ascertain whether the patient has any allergies such as to penicillin and what the nature of that allergy or reaction is. The third frame is a social history. So we'd explore the patient's social history. We'd find out how these patient's symptoms and conditions are impacting on the patient's life and occupation. We'd also need to inquire about smoking, alcohol, home circumstances as well, and occupational factors. We'd also then need to move on to the family history, particularly in relation to the presenting complaint and other serious conditions that could run in the family, such as cardiovascular disease, hypertension, or diabetes, or even asthma. The final frame is to explore the patient's values. Why is the patient worried about their condition? So there, we would need to explore the patient's ideas about what they think is going on, what concerns them most, and also to ask them about their expectations of how we can best help the patient. Then there should be an opportunity at the end to let the patient ask you further questions, but also if there's any bits of information that they would like to give you. Then usually at the end, it's a good idea to recap the main features of the history back to the patient just to check that you've got all the main facts. And then you could move on to a discussion about the management, which would include an explanation of what's going on, investigations, and follow-up.
Now look at extract 2. Extract 2, questions 37 to 42. You will hear a clinical pharmacist called Emma Royce giving a presentation about the side effects of certain types of medication. You now have 90 seconds to read questions 37 to 42.
My name's Emma Royce, and today I'd like to talk about some unanticipated side effects of certain widely used medications. The side effects that I'm particularly interested in involves changes in a patient's behaviour. In particular, the onset of what's known as compulsive or pathological gambling in patients suffering from Parkinson's disease. Pathological gambling is essentially an addictive disorder in which the patient feels a need to engage in financial risk-taking in the expectation of gaining a reward. It is characterised by both recurrent and persistent behaviours and can lead to significant distress and the breakup of personal relationships. The condition is thought to affect around 1.4% of the general population, a figure which rises to 7% in Parkinson's patients. It was this finding that led to the realisation that there was a link between the medication prescribed for that condition, notably dopamine agonists, and the onset of pathological gambling. So, how common is this side effect of Parkinson's medication? On the surface, it would seem that it remains the exception rather than the rule, only affecting around 1 in 7 users, and not all of those in a severe way. Also, because only a small proportion of patients treated with dopamine agonists develop the symptoms, it may reflect specific predisposing factors. The exact level of incidence is unknown, however, and this may be because many cases go unreported. Patients themselves or family members don't admit to the condition out of shame, or because their doctors or carers haven't been able to identify it. And this could explain why it doesn't show up more frequently in pharmacovigilance reporting systems. Let me give you an example of a typical case. A 74-year-old male, let's call him Harry, who was diagnosed with Parkinson's disease and prescribed the dopamine agonist pramipexole. About a month after commencing treatment, he began to feel an increasing need to play slot machines until he was going to a gambling venue every day. At first, Harry was able to conceal his behaviour from family members, another common feature of the condition. His wife did notice other symptoms, Harry was having difficulty sleeping and wasn't finishing his meals, but she put these down to his Parkinson's. It was when Harry began impulsively buying items that he neither needed or wanted that his wife became alarmed. It was at this point that the hole in his bank balance caused by the gambling came to light, and the couple was able to seek help. In other cases, heightened sexual activity has been identified as an indicator. There are several underlying risk factors for developing pathological gambling: male gender, a previous or family history of gambling, personality traits such as high impulsivity and high novelty seeking. The risk increases when such people take dopamine agonists as treatment for Parkinson's disease. Originally, research suggested that the higher the dose, and the longer the duration of the prescription, the greater the likelihood of compulsive symptoms occurring. More recently, however, research into the use of the medication for another condition, restless legs syndrome, or RLS, has shown that symptoms can develop even at low doses. So, what are the long-term effects of these adverse reactions? Pathological gambling seems to be reversible when the dose of the dopamine agonist is reduced, or the patient is transitioned to an alternative medication. Basically, dopamine agonists help Parkinson's patients by replacing the loss of dopamine in areas of the brain that control the ability to move. But the increased dopamine levels then affect other areas, such as the neural system linked to pleasure and reward behaviors and associated emotions, which then manifest themselves as impulsive and compulsive actions. But the effects are not long-lasting. Harry lost all interest in gambling within a month of stopping pramipexole therapy. But sadly, for many patients, the problem isn't picked up before life-changing disruption is caused, as significant gambling debts develop and relationships become strained. So, what can we do to improve the management of these side effects? There's no doubt that Parkinson's is a serious and degenerative disease, so the drugs may represent a reasonable trade-off in terms of risk-benefit analysis. It's hoped that by educating patients and carers about potential side effects, it'll make them more willing to report changes of behaviour. Patients and their carers should be monitored closely for the symptoms, so that as soon as any side effects do emerge, the drugs can be tapered or discontinued. For other conditions, such as RLS, however, it is open to debate whether the risks associated with compulsive behaviours outweigh the therapeutic advantages of administering the medication. What is needed is further research to establish just how extensive the problem is.
That is the end of Part C. You now have 2 minutes to check your answers.